Hi, I'm Dr. Raj Aquila. I have over 15 years experience in cosmetic dermatology. I'm based in the UK, but one of my principal roles around the world is as a global key opinion leader in medical facial aesthetics. When addressing a case of female beautification in a young female patient, it's important to outline some of the geometric and mathematical rules and guidelines and try and adhere to those to generate ratio, proportion and harmony in the face. For example, if we take the rule of horizontal thirds from the hairline to the glabella, to the nasophiltral angle, to the menton, these 3 thirds should be equal in length. And you can see that in our patient who is extremely beautiful, she has slight frontal elongation when compared to the lower third, which is slightly short. This would potentially justify an injection in the chin for elongation. Also, it would justify support of the lateral eyebrow to generate lifting to give the illusion of upper third shortening. The next thing that we look at is the rule of the vertical fifths. So, the female chin width, it should be the same as the female nose, which should be the same as her intercanthal distance, and it should be the same as the distance of the width of the eye and the width of the lateral fifth of the face from the lateral canthus to the hairline when viewed in the AP position. You can see that in our model, she has slight widening of the chin. The relationship between the nasal width and the intercanthal distance is perfect. The eye width is in perfect harmony with the intercanthal distance, but when you look at the lateral fifth of the face, you can see that there's a slight narrowing which justifies an injection into the temporal fossa and also into the zygomatic arch. When addressing extreme female beauty and trying to optimize the aesthetic of our patients, especially when they present young to us, it's important to look at some angles and ratios to optimize the aesthetic result. For example, the eyebrow axis, the canthal axis, the zygomatic axis should be in harmony of parallel sequence, typically between 12 and 14 degrees in the female patient. The 12 to 14 degree rule also applies to the posterior convexity when assessed in the lateral view, and we can see here she has a perfect conformity towards 12 to 14 degrees. When we assess the lateral view, it would be optimum to have a nasofrontal angle between 130 and 120 degrees, a nasophiltral angle of 95 to 105 degrees, and also here the relationship between the nasal tip and the pagonian to form an anterior limit for the lip, and preferably to have a distance of 2 millimeters posteriorly for the lower lip and 4 millimeters for the upper lip. You can see that the lip is kissing the pen, which justifies a slight anterior rotation of the chin, and therefore injection at the pagonian would be desirable. Now when we look at the lower third of the face, in the female patient, we want to see 1/3 to 2/3 relationship between upper lip and chin, and that relationship should be reciprocal within the lip itself, so 1/3 to 2/3. You can see that our model is hitting the numbers absolutely perfectly. Finally, when addressing the jawline, of course it's important to have a uniform transition from the chin through the jawline, and once it hits the angle of the mandible in the female patient, it's desirable to have an angle of between 94 and 100 degrees, meaning a slightly steeper jawline. In summary, the injection points required following the geometric plan. Firstly, temporal injection to give widening, but also to facilitate better elevation of the lateral eyebrow and to improve the lateral canthal axis. Injection of the zygomatic arch to generate lifting and indirectly treat malar mound, tear trough, and nasolabial fold. A further injection into the SOOF in the mid-pupillary line to improve anterior projection of the medial cheek but also to indirectly deal with the tear trough, which can make our patients look tired despite high levels of aesthetic score. If you look to the ceiling now, you can see that during upward gaze there's a slight opening of the tear trough medially, but there's a definite depression here at the lateral lid-cheek junction, and we know that by injection here onto the bone you can give vertical elevation of the lateral canthus, in effect creating the effect of an injection canthopexy. Now, in addressing the lower third of the face, we have a labiomental crease, which exacerbates the appearance of shortening of the chin because of activation of the mentalis muscle. So we can deal with this complex by injecting into labiomental crease, into the apex of the chin that facilitates both anterior and inferior projection of the chin. It's important to assess where the vertical concavity lies and identify prejowl sulcus, injecting upwards towards the oral commissure and increasing the superficial injection from the bone, submuscular plane and intradermal level. Finally, in the chin region, identify the transverse depression which demarcates the upper limit of the mentalis muscle. And we unite the labiomental crease in the midline to its lateral extremity as it intersects the mandibular retaining ligament by injecting in between the 2 points. So in summary, with our model today, it's a 10-point beautification strategy to take the patient towards geometric ideals, optimize beauty, whilst not distracting from any of the existing strengths in the face. So let's go through the 10-point injection strategy for our female patient adopting a beautification approach. The first point is the temporal fossa. What we know is that the superior medial quadrant of the temporal fossa, within a square centimetre from the temporal fusion line, is the safest injection point because we've got the thinnest part of the temporalis muscle, which takes less blood supply, and therefore it negates the risk that exists in the lower third of the temporal fossa. Palpate for any frontal branch of the superficial temporal artery. View for any veins that are visible through the skin. Give a slight lifting and tension and traction onto the orbital retaining ligament. And then we inject perpendicularly down onto the bone. It's always important when you're injecting high-risk areas to give aspiration. I hold for 3 seconds, and once we're safe to inject, we proceed. Now, typically the volumetry here is between 0.3 to 0.5 cc. In a shallow temple like this, we're looking at around 0.3 cc. Slow injection. Watch the product flow beneath the deep temporal fascia. It can't flow superiorly or medially, so it must flow inferiorly and laterally, which gives excellent lifting capacity for the eyebrow, lateral upper eyelid, and the lateral canthus. It's a self-molding injection because the product is flowing beneath the temporalis muscle, but you can paddle the product down, and also to facilitate lifting, give slight lateral traction. Now for the second point, zygomatic arch. In the assessment of this point, must palpate the notch on the lateral cheekbone, which represents the suture at the union between the 2 bones. This has an attachment between the skin and the bone, a retaining ligament, which falls during aging medially. If I palpate the notch and I place a ball of product where the notch is, this represents the cutaneous insertion of the retaining ligament. As I retract the tissue and then place the product where the notch was, this represents the bony origin of the retaining ligament. Therefore, injection medially to the origin and release of the tissue allows the retaining ligament to fall on top of the product. So we give slight retraction, inject perpendicularly down onto the periosteum at the level of the notch, and at this point we inject typically between 0.1 to 0.3 cc. The moulding here is important. I retain the tissue in a lateral position and then mould laterally to generate a degree of adhesion, but also some structural lifting in the lateral cheek. Now you can see here that the vector of lift from the lateral cheek all the way through to the nasolabial fold has been affected. This means the malar mound reduces, the mid-cheek groove is reduced, lateral lid-cheek junction improved, tear trough improved, and nasolabial fold also reduced. For increased impact in the zygomatic arch, you can mould along the inferior border of the zygoma to give a more dramatic subzygomatic transition, essentially giving the effect of better contour in the midface. You can see that our patient already has good lateral projection in the zygoma and is naturally blessed with a prominent zygomatic eminence. Medially, however, she's deficient. So the target here is to inject the level of the SOOF underneath orbicularis oculi muscle to give anterior projection, but also to do an indirect correction for that slight infraorbital depression. We inject from an inferior lateral position to negate any risk with the infraorbital foramen, very gently with a tactile resistance through the skin, the subq fat through the muscle, and then we get into the SOOF. I'm going to make an injection here of between 0.1 and 0.2 cc. We can see an immediate correction within the tear trough. And the moulding should take place in a medial position, upwards towards the trough. And especially in skin of colour, you can see a beautiful lightening of this infraorbital skin when compared to the non-treated side, and this is a fantastic remedy for dark circles. Now moving to the next point, the lateral lid-cheek junction, to give vertical elevation of the lateral canthus, essentially making the eye more beautiful, but also giving the impression of an improved mood in the lateral eye. Look to the ceiling. Always orientate the needle in the same orientation as orbicularis retaining ligament, and therefore you'll notice that I'm injecting from a posterior position. Retract the skin, inject down onto the lateral orbital rim, just inferior to the lateral orbital ligament, and we take this product and mould upwards against that lateral canthal ligament to give an upward flick of the lateral corner of the eye. We know this is hugely effective because our patients are applying eyeliner pencil and making an upward gesture, because we know that as you age, there is a descent of the lateral canthus. Now moving to our fifth point, prejowl sulcus. And elevating the injections from prejowl sulcus to oral commissure to try and give better support to the corner of the mouth. Compress the tissue to identify the cutaneous insertion of mandibular retaining ligament. Always injecting medial to the ligament as to not place product within the jowl fat compartment. Down to the bone. And as we make an injection, the most important aspect of this correction is the moulding to give a better union between chin and jaw.